VASC system. And we appoint a score for each of these diagnoses. Has the patient had heart failure? Do they have a diagnosis of hypertension? We're not talking about whether it was treated or not. Do they have that diagnosis? That gives them a point. Are they over 75? That gives them 2 points. Are they diabetic? 1 point. Have they had a prior stroke or transient ischemic attack? That gives 2 points. Do they have evidence of peripheral vascular disease? Age over 65, female sex, all of these are risk factors for stroke. So the worst number you can have is 9. And what does that mean? Well, this is what happens. The higher your chance at VASC score, the greater the risk of stroke. So the adjusted stroke risk per year is listed here. So if you have a score of 2, which means simply a prior TIA, your risk of having a stroke in the next year is 2.2%. If you're hypertensive and 76, your risk is 3.2%, because that right off the bat gives you a score of 3. And people should be anticoagulated basically if they have any score above 2. 1, there's some debate about it. 0, we deem them to be at low enough risk that perhaps they do not need to be anticoagulated. So when I'm trying to convince a patient about the importance of this and the importance of reducing the risk of stroke, one of the useful things I have is to take my little trusty computer, the iPhone again. I have a little calculator on that, and we can just go through, answer the question, and we come up. And when you tell a patient, hey, you know, you have a 7% risk of stroke in the next year if we don't do anything about this, that can be very, very persuasive and much more likely to get compliance with the intervention that we want to pursue. Now this is interesting information that just hot off the press basically. This is from the Heart Journal, and this has to do with something called the Garfield Registry, which is a large ongoing prospective study out of London looking at atrial fibrillation patients in 35 different countries. And basically what this slide is talking about is the evolution of anticoagulation management practices over the last number of years. So on the left is cohort 1. These are patients that were enrolled from 2010 to 2011. Cohort 2 is the next year, 3 the next year, and 4 the most recent. And then each of these color bars indicate the anticoagulants that were selected. So this is VKA, which means Coumadin and aspirin, the 10A inhibitors, the direct thrombin inhibitors, aspirin, or no treatment at all. So, you know, I think the comment came up that we have patients that we know that are at risk but they're not being treated, and that actually is true. But the data from this trial at least suggests that we are making some progress. So the number of people not treated at all has kind of plateaued, I guess. You know, there obviously are some people in whom the bleeding risk is just unacceptably high, and we have to make that decision. You know, is it worth putting them on a preventative, particularly if the preventative causes another set of complications. But nonetheless, the irreducible minimum should be less than this. So we're seeing much less use of aspirin and more use of the direct thrombin inhibitors in this pattern and the 10A inhibitors particularly in this pattern. These are the new drugs I was referring to earlier on. So basically, as these have become available and more widely used and discussed, they are being used more extensively. And then when you break it down by the actual CHAS-VASc score, now remember I did tell you that the CHAS-VASc score of 0 people probably do not need to be anticoagulated, but there are some exceptions to that. There are situations like in our ablation patients, we want to keep people on anticoagulants for at least some time. If we are taking people in for cardioversion, also these folks would need to be on it for some time, regardless of their CHAS-VASc score. But again, just to reinforce the point that I think we are making some headway, but there is still room for improvement in terms of getting people to take anticoagulants. Now, which new drug should we recommend? Or should we take a person who's on Coumadin off Coumadin and switch them? My philosophy has been, if it ain't broke, don't fix it. I mean, if people have been doing fine on Coumadin, if we've been maintaining therapeutic INRs, and in many cases that is so, then I will tend to just maintain status quo. Generally speaking, if I'm facing a diagnosis about initiating anticoagulation for the first time, I would recommend the novel oral anticoagulants simply because of the ease of use. And as regards to which one, you know, sometimes the insurance company will tell me which one on the basis of cost to the patient. People with GI symptoms may not wish to take Pradaxa. If there are compliance issues, people have a tough time remembering to take drugs twice a day, you might opt for one of the single-day drugs, although many of these patients are on multiple times a day drugs already. So these are the kind of questions that we go through when we're making a recommendation regarding which of these to use. But I will say, any of them is better than nothing. Now, hot off the presses, some new developments with respect to mitigating stroke risk. Not everyone can take Coumadin or one of these anticoagulants, or they fail. So there has been a new device just approved by the FDA called the Watchman. And this is a device that plugs into the left atrial appendage. Again, it's delivered percutaneously through the vein of the leg, not unlike the ablation procedures I described earlier on. And again, the notion is that if clots develop inside the heart, they most likely are to develop in this outpouching called the left atrial appendage, like an appendix. And in fact, that's probably true. The data suggests that 91 to 92% of all intracardiac clots start in the appendage. The idea then is that we take this plug and we stick it in the atrium, and over time the inner lining forms a cell membrane that endothelializes, and you basically exclude the appendage. Therefore, that little nook and cranny where the clots may form goes away. So that has been approved and is currently being used. Another technique that's being used is kind of an intriguing technique called the lariat. In this situation, what we do is we bring a catheter with a little magnet at the end of it, again into this appendage from the inside, and at the same time we put another magnet into the pericardial space from the outside, and we get the two magnets to pull together in the center, just at the tip of the appendage. And then when we have a kind of a rail, we can slide a suture over the outer layer and cinch down in the appendage and get rid of that one. A little bit trickier, not every anatomy is appropriate for that, and there's a lot of controversy as to whether it's the right thing to do or not. But and these are very expensive technologies. So interestingly enough, when the FDA approved this, this is what they said. The left atrial appendage device is approved to reduce the risk of thromboembolism from the appendage in patients with non-valvular atrial fibrillation who are increased in stroke and are recommended for blood-thinning medicines, and who have a legitimate reason to seek an appropriate alternative. Well, that sounds like an awful lot of people, doesn't it? I mean, this thing could bankrupt the system if we started applying it widely. And furthermore, you know, it's not without risk, as you can imagine. So the CMS has come up with much stricter guidelines about who should get this, and they have insisted, among other things, that there be a formal registry that patients have to be enrolled in. There has to be an independent documented consultation by another physician who agrees with the process, but who is not actually involved in the procedure. And I think these are very, very reasonable, legitimate restrictions on the device. And this registry has to be maintained for a minimum of 4 years. So we will have ongoing data over time as to whether or not this is a legitimate and effective therapy. The cost of this, I think, is about $30,000 per patient. Okay, so what else is happening? You may have been aware a couple of years ago about a lot of excitement about renal artery denervation as a technique to treat hypertension, but it kind of fell by the wayside because of a major study that essentially bombed. But in the arrhythmia world, we have come to recognize that renal arteries are very much involved in some of the arrhythmias we deal with, including atrial fibrillation. So we have an ongoing study at the present time that is going to look at the idea that if we denervate the renal artery, and by this we will put a catheter up through the artery in the leg into the kidney arteries, use that ablation technique to burn the nerve endings, and at the same time do that freezing balloon thing I described earlier on, and we're going to see if that actually improves the outcomes with respect to atrial fibrillation ablation. So that's a study that's ongoing. Another interesting new development is hybrid technology, working with the surgeons in situations where the atrial fibrillation is more challenging than we alone can undertake. Not everyone is happy with that big open chest procedure I described earlier on, but there is a more miniaturized procedure where we can just insert a catheter through the underneath the bone here, the breastbone, into the back of the heart, into the space behind the heart, and the surgeon will do the blue ablation, as you can see here, with his step tools, and then when he's done, we can move the patient to the EP lab and finish off with that freezing balloon technology we talked about. All right, but one final thing I want to bring to your attention is a very interesting study that really kind of blew our professional society in a loop about 2 years ago when this data was presented in San Francisco at the national meeting. And it is data from Australia about a trial called the ARREST-AF trial. Very interesting study. So they were taking their patients who were undergoing their first ablation for atrial fibrillation, and they took those who had a BMI greater than 27 and at least one other cardiac risk factor. And that turned out to be 165. Now here it'd be a much higher percentage, but this is Australia. So they said to these folks, they were offered an aggressive risk factor management, and I'll tell you what the risk factors are present. And half of them said, okay, let's listen now, we will accept this aggressive risk factor management. And this included physician-directed supervision of diet, diabetes, recording blood pressure 3 times a day, and so on. And the other group said, no, we'll be good people, don't mind us, just give us the instructions and we'll follow what you say. And then they looked at the outcomes, and here's what happened. In terms of the outcomes of the ablation, those folks who had the aggressive intervention had dramatically better results than those who did not. And for instance, when I didn't have time to present all the data here, but those people who had aggressive intervention basically lost about 10 kilos over the course of a year. But the key point here is when they had the ablation done, the ablation was much more likely to be effective. This is the outcome for a single procedure in the group that had the intervention compared to the control group that did not have the interventions. And similarly, when they had a requirement for multiple procedures, far superior outcomes. So these are the things they focused on in particular: blood pressure control, weight management, lipid management, blood sugar control, sleep apnea, smoking and alcohol. All the kind of things you've been talking about here earlier on. And this is the intervention they aggressively pursued, and it turned out to have a really dramatic effect on the outcomes of the ablation technique. So, in summary, I just want to share with you atrial fibrillation is common, it is a dangerous condition, very important risk factor for stroke. We use the CHADS-VASc scoring system to estimate the risk of stroke and to advise patients about anticoagulants. It would seem to me that the new agents that we have available are safer and more effective than Coumadin. We're going to see more and more with respect to those interventions in the appendage that I described towards the end, and our technology with respect to ablation and surgery continues in evolution. Thank you very much. Questions? Yes?
Question. How is AFib related to cardiac arrest? I know you're talking about the increase in stroke. Isn't there an increase in cardiac arrest too?
Not really, other than atrial fibrillation is associated with a decreased survival. So in general, the mortality is increased, but that can be for many reasons, including heart failure. There is one particular situation where atrial fibrillation is in fact associated with sudden death, and that is if people have a congenital pathway called a Wolff-Parkinson-White pathway, which is a thing that's often recognizable in an EKG. That can be a cause of sudden death actually in quite young people. They've got a perfectly normal structural heart, there's nothing wrong with the coronary arteries, but they just die suddenly. And unfortunately, there's no way of diagnosing that post-mortem. You'd have to have an ante-mortem diagnosis. But that is one scenario where people can have a cardiac arrest in the context of atrial fibrillation. Another context, actually, is the drugs we use to treat it. Some of the drugs can cause a cardiac arrest as well.
Because I noticed on your one graph where it said MI and it had, I didn't really understand the scores as far as 0.77, and that seemed to be a higher number. Is that because some of the drugs can cause other?
I think you might be referring to the anticoagulant table I presented, that the anticoagulants have a higher association of myocardial infarction in general from that meta-analysis, but that's not the atrial fibrillation, that's the drug treatment.
Right, that's the drug treatment.
Could you elaborate on that point? So you're saying when people are taking anticoagulants, that elevates the risk of MI?
Yes, but to such a small degree. If you look at the numerical change there, it is tiny. Compared to the benefit, it's minuscule. I would not use that to dissuade me from recommending the anticoagulants to mitigate the stroke risk.
So the way we came about inviting Dr. O'Neill here to speak is that Dr. Schatzel, our Mercy Telestroke director, talked about how atrial fibrillation is a very unrecognized risk factor. So can you talk a little bit about how the primary care community might use it more in screening. Should they be doing more EKGs during physicals? If they have an unusual EKG, what are the next steps?
Well, the problem with a lot of the screening and diagnosis is the fact that the atrial fibrillation may be asymptomatic. Number two, when it starts, it tends to be paroxysmal. So even if people come in with symptoms, when the doctor gets to evaluate them, they won't be able to see anything wrong. So routine EKG surveillance, I'm not aware of any data to suggest that that is really effective. Things like this phone app for people who have symptoms we talked about, very, very useful for people to actually make the recording. The problem with it, however, is this. People can have very, very short-lived episodes. So by the time you actually pull the thing out, activate the app, and get your fingers on it to make a recording, you know, that could take 15, 20 seconds, and the episode is gone. Which of course brings up another question, is just how much atrial fibrillation do you need to have in the first place to increase the risk of stroke? And the information of that is all over the place, and there's tremendous inconsistencies in our own literature. But the current, thinking that I think is most valid is data from a trial called the Trends, which suggests that any continuous 5.5 hours of atrial fibrillation in a 30-day period is a significant indicator of stroke risk. There have been studies from the pacing literature, because all the pacemakers and defibrillators we have now can record, date stamp, and time the amount of atrial fibrillation. There have been studies suggesting that in the heart failure population, episodes of atrial fibrillation as little as 6 minutes may increase the stroke risk. So getting back to your question, so the problem with this really is a lot of people will show up asymptomatic. You know, they come in for their first office visit, and we say they have it, and they said, we have what? We didn't know there was anything wrong. And interestingly enough, they don't, but when you put them back in sinus rhythm, and I nearly always give people the benefit of at least one go at so-called sinus rhythms, many of them will say, oh yes, now I can tell the difference, I have more energy, and so on. So, I think awareness is important. The cardiac societies have months, I think September is the atrial fibrillation month. A lot of media attention and exposure to it. You know, as I said, the television is bombarded with ads about the stroke risk, and then you have high-profile celebrities like Arnold Palmer who are, you know, talking about these things. But you know, short of putting a chip in everybody, which is just not doable, either cost-wise or ethically, I'm not sure what more can be done. The tools are there. The issue is using them. So I think patient awareness is important. I think being aware that a lot of the symptoms that they have, that they think are just because they're getting old, may have other physical explanations.
Can you talk a little bit more about the newer anticoagulants, their bleeding side effects
Right.
as compared to Coumadin?
Right. So pretty much across the board, we would say that the bleeding risk is less with the newer drugs than with Coumadin. One of the concerns initially when they came out was, well, you know, what happens if you have a bleed? You know, what happens if you get into a sword fight and show up in the emergency room? Because there are no antidotes, and people think that there's an antidote to Coumadin. Well, there is, but it doesn't work right away. I mean, vitamin K, fresh frozen plasma, they all take time. But it turns out now, the first of these drugs available, called Pradaxa or dabigatran, has a commercially available, immediately acting antidote or reversible agent called Praxbind. And with respect to the other drugs, the other 3 that are in the market, they're called 10A inhibitors, and the drug has been developed to act as an antidote for those. It has gone to the FDA. It has not yet been approved by the FDA, but we anticipate it likely will be in the near future. So that whole question is I think, but the reality is when you look at the numbers, when you look at the data, there is less bleeding with the newer drugs than there is with Coumadin. So if your goal is to minimize the bleeding risk, don't use the Coumadin.
Can you say a little bit about the monitoring piece of
Monitoring,
INR?
so INR. So INR is only applicable to Coumadin. There is no role for monitoring blood tests in the other drugs. And this was partly because of the historical imperative. We were always complaining about how much of a nuisance it was to do these INRs. But So when the drugs were originally developed, they were developed as a situation where you would not need to do this routine monitoring. Now, that seemed like a great idea at the time, and it is the way it is right now. You can do monitoring, you can measure levels and so on, but it doesn't really translate into any useful information other than assessing compliance. But when you're talking about using expensive drugs, right, then compliance may be an issue. And we have no way of assessing whether people have been compliant with the drugs. So that is definitely a worry. You know, if people are going to pay $500 a month for the drugs and the alternative is feed the children, it's an issue.
What
Yeah.
about just baby aspirin? I mean, you hear all the
Worthless.
time about just.
Worthless, absolutely worthless.
Worthless?
Worthless, beyond worthless, as far as stroke prevention and atrial fibrillation is concerned.
So, not all patients, like you said, are compliant with their drug regimen, so stroke still happens, right? When, even if the patient is on newer anticoagulants.
Absolutely, if you did, that's true.
And what, I mean, maybe it's Dr. Schatzel who can answer, what do you do in those cases? When you don't know for sure the patient is on this anticoagulants and then now patient has a stroke and you want to administer TPA or I mean, what do you do?
So there's large vessel strokes and small vessel strokes, so we got to differentiate those. It may be that some of the other risk factors for small vessel strokes have been appropriately addressed, and they may not, they're protected from maybe a large embolic type stroke, but a small vessel stroke could still occur. And that's an analysis we do when someone comes with symptoms. As far as treatment with thrombolytic therapy, when they're on some of these medications in Coumadin, we check immediately what's the INR, and we may be able to treat if it's below a certain level. We use 1.7 as a cutoff. With these newer agents, we struggle with that because we give them thrombolytic therapy and they're on these medicines and they're taking them appropriately, and they're at very high risk for bleeding. So in those scenarios, we might have to go directly to if it's a large vessel occlusion, we have to go directly to an interventional procedure to take the thrombus out of the blood vessel.
That actually also is another category. This is a patient basically who's failed anticoagulant. They've had a stroke despite anticoagulant. This is the kind of patient we may wish to consider these occlusion devices to isolate the appendage as an option. That is the subset where I think there may be some value. The problem, of course, as I pointed out early on, though, is that many times if people have a stroke in the context of atrial fibrillation, they may be quite disabled, and then it becomes a huge discussion as to just how aggressive we are going to be.
So we have one last question from Warren Barnes.
Quick question. If the atrial rhythm is essentially constant,
Yes.
what accounts for the variability in the rhythm of the ventricular rate?
If the atrial fibrillation is constant, why is the ventricular rate variable?
Not
So-
the rate. In both cases, the rhythm. Atrial rhythm is constant,
Yeah.
but the rhythm, the ventricular rhythm, how do you account for that not being constant?
Well, the atrial rhythm is not constant. They're all cases, it's chaos. And you are bombarding the AV node, the central connection between the atrium and the ventricle, with all this input from the atrium. And it just conducts variably. So that leads, when you feel the pulse, what you're feeling is the ventricular contraction.
So if the ventricular rhythm is not constant, the assumption would be that the atrial rhythm is not constant. Is that correct?
within limitations. The definition of atrial fibrillation is an irregular and irregular rhythm, so it has to be both irregular in pattern and rate. So you can have an irregularity, but it follows a regular pattern, and that may have nothing to do with the atrium. So it depends, but irregularly irregular, that's the thing. So when you put your finger on the pulse, and you can appreciate no consistent pattern to it, then almost certainly you're dealing with atrial fibrillation. But what you're feeling is the ventricle output.
So we are at the top of the hour, and we've had an amazing day with Dr. O'Neill. I want to say that we are going to have another amazing day here on November 14th, and it's going to be all day long. And we're going to have people from the university best practices from around the state coming together here for a full day of clinical information. A particular component will be on stroke. So I know a lot of you in the room today are have been following Dr. Arnie Milstein's work. It was presented, so that's, you know, when you don't prevent the stroke, then how do you manage the stroke? So I would love to have you join us, and please RSVP everyone. We've only got 80 seats here, and so please get your registration in early. Dr. O'Neill, we'd love to have you with us, and thank you, Dr. Schatzel, for bringing him to us today.